Hello, everyone, and welcome to ACS Webinars, connecting you with the best and brightest minds in chemistry, live from Washington, D.C. I'm Michael David, and I'll be your host for today's webinar, which is being co-produced with the Science History Institute. Today's moderator is Dr. Chung Feng, the Senior Vice President of R&D at Innovus Bio, a clinical stage biotech. A seasoned neuroscientist with over 20 years of expertise in neurodegenerative diseases, Dr. Feng brings a broad scientific insight, hands-on research experience, and a strong track record of both preclinical and clinical drug development. Before I turn it over to Dr. Feng, let's hear from Grace Sharpless-Cook, the Director of the Office of the President at the Science History Institute, to tell us a little bit more about this free museum and the library that collects, preserves, and shares stories behind the science.
Hello and welcome, everyone. We are very grateful for our collaboration with ACS in sharing these Joseph Priestley Society lectures. And as we start today's presentation, I'd like to remind the audience that there are many stories of science to be found on the Science History Institute website, including Distillations podcast and our digital magazine at sciencehistory.org/stories. We also have an interview with Jennifer Doudna on the discovery of CRISPR-Cas9, which you can find in the chat. We'd like to remind everyone that past Joseph Priestley Society talks are posted on our website. Please come back for more and let your colleagues and peers know about our lectures and other compelling programs in our museum and library and online. And now I would like to invite Dr. Feng to start today's talk.
Thank you for the introduction, and thanks everyone for taking the time from your busy day to join us. We have a very exciting webinar prepared for you. So it's our honor to have Dr. Jennifer Domm, the board-certified pediatric hematologist and oncologist from TriStar Centennial Medical Center, to join us today. She will present the power to edit DNA, CRISPR-Cas9, and sickle cell disease, a devastating inherited of blood disorders. CRISPR-Cas9, I think many of us are quite familiar. So the pioneers of this breakthrough gene editing technology, Drs. Jennifer Doudna and Dr. Emmanuel Charpentier, were rewarded a Nobel Prize in 2020. December 2023, FDA approved the first gene editing drug based on this technology to treat sickle cell disease. And Dr. Jennifer Domm is in the pioneer in making this disease, making this therapy happen. So she will tell us all about it. Without further ado, Dr. Domm, the floor is yours.
Okay, good afternoon, everybody. Thank you for having me. I am going to introduce today the topic of sickle cell disease, kind of a little bit about the history and the disease itself, and then we're going to talk about some exciting new developments that we have for new treatment paradigms for these patients. So I look forward to sharing with you my experiences, as well as encourage you again to ask any questions and let me know if there are things that I can provide more information about as we go. Okay, so briefly, I wanted to just give you a little bit of information regarding sickle cell disease. So it was first described in the year 1910. The first described case was a 20-year-old who had leg ulcers, body pains, anemia, pallor, jaundice, and fever. And a publication regarding this case study noted peculiar, elongated, and sickle cell-shaped red blood corpuscles in a case of severe anemia. And it was also noted that there were a large number of thin, sickle-shaped and crescent-shaped red blood cells in the peripheral blood smear by Dr. James Herrick. In April 1907, the young man reported that he had been laid up in a hospital from December 26, 1906 to February 26, 1907, so of note 2 months, with what he called muscular rheumatism. His illness had begun with malaise, pain in the back, the muscles of the legs and arms. He had a slight fever and was pale. The article goes on to describe the shape of the reds was very irregular, but what especially attracted attention was the large number of thin, elongated, sickle cell-shaped, and crescent-shaped forms. So you can see in the photographs, the microscopic photographs on the right, the very notable sickling of these cells as compared and contrasted to some of the normal cells you see in this slide, which have that kind of central pallor, which is the classic shape of a normal red blood cell. So you can see definitely the contrast there. In 1923, Hux and al. Studied a large pedigree that described patients with sickle cell trait, which of course is the latent form of the disease. And then in 1933, Lemuel Diggs did a population study in Memphis, Tennessee, of about 2,500 African Americans, and determined a carrier prevalence of around 8%. In 1940, Irving Sherman found that sickled cells, in the absence of oxygen, transmitted light differently than normal cells. In addition, Sherman suggested that the rate of deoxygenation contributed to the degree of distortion of these red blood cells. So a little bit about the incidence and distribution of this chronic and very severe disease. In the past 20 years, there are about 40,000 confirmed cases in 76 million newborn babies in the United States. Among African Americans, about 1 in 360 newborn babies have sickle cell disease. And you can see the population distribution map here with the colors referenced in the lower left corner. A few other highlights include the fact that in Brazil, there are an estimated 30,000 individuals with sickle cell disease. And then moving on in the map, most affected individuals are born in Nigeria, Congo, and Italy. And in sub-Saharan, and India, excuse me, most affected individuals are born in Nigeria, Congo, and India. And in sub-Saharan Africa, the incidence of births with sickle cell anemia was estimated to be about 230,000 in 2010, which corresponds with about 75% of births worldwide of patients that have sickle cell anemia. So very, very large numbers. I wanted to give a little bit of background, which probably many in the audience are familiar with, but I wanted to give a little bit of background about what normal adult hemoglobin looks like. Hemoglobin, of course, is the protein that carries oxygen from the lungs to the tissues, and it is a tetramer composed of 2 alpha-like globulin chains and 2 beta-globin chains. So you can see the graphic there on the right showing the tetramer of the chains, as well as heme and iron as part of this tetramer. So when we do testing for what kinds of hemoglobin persons have, the normal adult hemoglobin electrophoresis would be a combination of hemoglobin A for adult, A2, as well as hemoglobin F. You can see the percentages there. So in somebody that has a normal adult hemoglobin, they normally have 97+% that are a variation of the hemoglobin A, which again is the normal adult hemoglobin, and possibly a very small detectable amount of fetal hemoglobin. So we're going to talk a little bit more about what is important about fetal hemoglobin, but we do know that patients with disorders of beta globin chains do start manifesting the clinical features of their diseases as the natural change in hemoglobin F to A happens. And I'm going to talk and show you a little bit more about that. What is fascinating about sickle cell disease, and this is something that I remember from just, almost day one of medical school, it is a very unique disorder in the sense that there is one amino acid change that causes this whole problem to come to fruition. This was described in 1958 when Ingram reported that hemoglobin S is caused by a mutation in the beta-globin gene, in which the 17th nucleotide is changed from thymine to adenine, which you see highlighted here, and that causes the 6th amino acid in the beta-globin chain to become valine instead of a glutamic acid. So pretty fascinating that you have this one very small change that leads to a disorder with such significant morbidity and mortality. The pathophysiology of sickle cell disease is that these are cells that are, again, abnormally shaped. So red blood cells have a high concentration of hemoglobin, requiring the protein to be extremely soluble. When sickled hemoglobin or hemoglobin S is deoxygenated, it results in a hydrophobic interaction with another hemoglobin molecule, triggering an aggregation into very large polymers. And this polymerization of deoxygenated hemoglobin S is the primary event in the molecular pathogenesis of sickle cell disease, which results in a distortion in the shape of the red blood cell and a marked decrease in its deformability. And these rigid cells are responsible for the hallmark of this disease, which is the vaso-occlusive phenomenon leading to significant pain crises in this population. This is a graphic just showing you a little bit at all levels, molecule, polymer, and cell, what these changes look like. And you can see this polymerization of these cells on top of each other, which again lead to this sickle phenomenon. So deoxygenation again leads to polymerization of these cells, which leads to multiple subsequent ramifications. So on a cellular level, this is a form of hemolytic anemia, where patients are having chronic hemolysis happening all of the time with their cells. So what do we see clinically when we draw lab work for these patients? We see increased inflammatory markers. We do see markers that are indicative of ongoing hemolysis, including an elevated LDH, decreased haptoglobin. We also see varying degrees of anemia, including potentially very severe anemia. And of course, as part of the hemolysis, these patients are elevating or showing hyperbilirubinemia. What does this mean for patients clinically? Because these cells are polymerizing and not able to freely get through the circulation, patients manifest various symptoms, including symptoms of infarction in every organ possible. So specifically, this can lead to significant tissue damage subsequent to infarction, as well as what is, again, the cornerstone of this disorder, which is vaso-occlusive crises and pain. I think this is a really nice graphic as well as a photo, just to kind of how I would describe this to patients when I meet maybe a new family, a new child in the clinic. But you start to have this backup, essentially like we have on the highway here, a backup of these cells that just can't get through. And again, that leads to ongoing problems with fluid getting to these vessels, and of course then leading to more deoxygenation and more problems with bringing oxygen to tissues to function normally. As I mentioned, I think this is a classic disease to talk about even from day one of medical school, because you can really speak of any organ system and identify a problem that patients may have because of their sickle cell disease. So this is a slide and a photograph just describing many different issues that can come about because of this pathophysiology, including retinopathy, which we see in the upper left corner, pulmonary disease, pulmonary hypertension, bone necrosis, osteonecrosis, avascular necrosis. You can have infarcts everywhere, including infarcts in the brain, which of course would lead to a stroke. Patients can have renal failure, priapism, and skin ulcers, to name a short list out of a very long list of problems. The morbidity and mortality related to sickle cell disease remains, even in our current year 2025, still quite significant. In the US, the cost of caring for patients with sickle cell disease exceeds $1 billion annually. And shockingly, in a study of adults from 2003 to 2016, the median survival for these patients was only still 48 years. And you can see in the chart on the right-hand side, again, kind of all of the complications that these patients do potentially have. This is some mortality data as far as cause of death for these patients. And of course, mortality data is only as good as what is documented in the medical record and on the death certificate. But you can see most of these are related to end organ damage, mostly related to inflammation. So what kind of therapies are available for medical management and medical symptom modification of this disorder? Of course, a cornerstone includes supportive care, which as a hematologist, we see regularly at any given time. We generally always have sickle cell patients on our service. The mainstay is doing supportive care for these patients, which mostly involves hydration, pain control, etc. It is important to make sure that you appropriately immunize these patients because they, again, can have end organ damage involving the veins of their spleen, which leads to the spleen not being able to mount infection control as good as somebody else. So the mainstay is to put young children on penicillin prophylaxis until generally at least the age of 5 years. Doing pneumococcal vaccine earlier than you might for others in the population. Sometimes transfusion therapy might be indicated again if a patient is having ongoing hemolysis and severe progressive anemia. And then medical management includes medications like hydroxyurea, which works by increasing your hemoglobin F, of which we're going to talk a lot more about. There are other medicines, including glutamic acid and other mechanisms of action, including selectin inhibitors. And I put some medication, voxelotor, which is a hemoglobin S polymerization inhibitor, in parentheses because that was something that we had available. And within the last, I think, 6 to 9 months, it has come off of the market because of some post-marketing data that came to light. So you see the list of medical options that we have to modify this disease is fairly limited. And there's not a whole lot that's really new in this area recently. One thing that has been explored that I personally have also been quite involved with is using stem cell transplant, specifically allogeneic, meaning from another person, as a curative therapy for this disease. As the field of transplant has evolved, we have had the ability to use alternative donors, which I'm happy to talk in more detail about if anybody has any questions. But the original transplant that was used for sickle cell involved those that were matched related donors. And only about 10% of patients have an HLA identical donor. So you see, even if this is something that we wanted to explore for a patient, the likelihood of them having an HLA identical donor is quite small. Okay, and then I just wanted to give you a little bit of background about the use of HLA identical sibling hematopoietic stem cell transplants for these patients. You can see the Kaplan-Meier curves on the right-hand side. The top graph is, actually, let's start with the bottom graph. The bottom graph is overall survival and time from transplant. Again, these are HLA identical sibling matches. And you can see the 3 different lines. There are different sources of hematopoietic stem cells. Cord blood, peripheral blood, and bone marrow. which are all various ways that you can collect and then infuse stem cells. So you can see the overall survival rates there are fairly good for MAPS-related donors, but again, the availability of them are quite small overall. One significant complication related to stem cell transplants, variable, of course, based on the cell source, but is the possibility of graft versus host disease, which is essentially the fighting between the new donor cells and the patient, the recipient's body. So those that is definitely a risk for patients, and it can create very significant long-term organ issues, including skin, liver, GI, etc. And so the graph on the top right-hand side is looking at chronic graft versus host disease, which is that immune response to the new cells over a period of time. And that top graph on the right-hand side looks at time from transplant as well as cumulative incidence of chronic graft versus host disease. And you see that it is reaching close to around the 20% mark for peripheral blood, and somewhere around the 10 to 15% range for bone marrow as a source. Okay, so the next step in terms of the evolution of transplant was thinking about how we could potentially open up transplant as a possibility for more patients. Again, referencing the fact that there are only about 10% of patients that do have an HLA identical related donor identified. So Shalini Shenoy did publish a paper in Blood in 2016 proposing this very extensive conditioning regimen that you see on the right-hand side for patients that were going forward with an unrelated donor bone marrow. And you can see the patient demographics. The median age was 14 years. The range was from age 6 to 19. And then the patients that were brought to transplant, obviously, out of the 29 total, there were 12 that had a prior history of stroke, as well as many other problems listed below, including acute chest veno-occlusive crises and abnormal transcranial Dopplers. This is the Kaplan-Meier curve for patients over time. The months post-transplant is down on the x-axis, and you can see the event-free survival data on the left as well as the overall survival data on the right. So you do start to see over time, certainly those numbers do slowly float down, and you can see the actual EFS and OS numbers on the graph there. And then these graphs are looking at, again, chronic graft versus host disease on the right-hand side, and what we would call acute graft versus host disease, which is generally defined as having symptoms within the first 100 days post-transplant. And you see the incidence of both acute and chronic does increase over time, and it is not insignificant. It is still potentially quite high, which again can essentially trade one major disease for another major disease. Okay, so this is a CTN trial looking at conditioning for a haploidentical bone marrow transplant in adults that had sickle cell disease. And these are patients that have a half or haplo bone marrow as a source. So that generally could be a family member, including as a pediatric provider. This is something that I would see, maybe we would test parents to see if they were a good match to be a half-related donor for their child. And you can see in the graphic form here what that conditioning regimen looks like, as well as the event-free survival for these patients was 88% at 2 years post-transplant. Okay, so now let's get into a little bit about the CRISPR-Cas9 and the different techniques for these processes. So there are approved therapies now that use a gene addition technique, and there are therapies that use gene editing processes. And you see here the graphic for how the patient timeline proceeds is very similar. We're going to go through that in a little bit more detail. But the difference here is predominantly in how these cells are externally manufactured. Again, either with a gene editing technique or a gene addition technique. All of these patients do need their stem cells collected, and then they're sent for manufacturing and then reinfused into the patient in this common pathway down below after they receive preparative chemotherapy. So I'm going to focus my talk on specifically the gene editing version. There are, again, a whole nother talk is on gene addition. But I'm going to focus on the CRISPR-Cas9 and gene editing. So why is this potentially very, very important and truly potentially life-changing for these patients? Gene editing tools, as you all very well know, lead to very precise changes in the DNA. And so these tools allow genetic material to be disrupted, deleted, corrected, or inserted at precise locations, at specific locations in the genome. Several ongoing clinical trials using gene editing to treat sickle cell disease, as well as transfusion-dependent thalassemia, are ongoing. And I'm going to specifically focus and show you data on the gene disruption to induce fetal hemoglobin production. So we're going to look at some of that very, very exciting data. Okay, so we need a little bit of background in order to talk in more detail about how this works. And so in order to do that, I just wanted to show you this transitional slide, this transition for hemoglobin as to how hemoglobin changes from fetal hemoglobin to adult hemoglobin, F2A. And of course, when a fetus is in utero, they are not exchanging oxygen with the environment. They are exchanging oxygen through the placenta. So there's a very unique subtype of hemoglobin, hemoglobin F, that has a very high affinity for oxygen in order to extract oxygen from the placenta. Once the baby is born, suddenly that switch gets turned and the hemoglobin F starts to change to hemoglobin A, which is what we looked at in the beginning of this talk. And you can see, based on gestational age, how that hemoglobin F is going away and how your hemoglobin A is coming into play around this 3 to 6 postpartum time of life. And so this is the time where if patients do have sickle cell disease, they are going to start making hemoglobin S instead of hemoglobin A. And this is a time where patients are going to start developing symptoms, some of which we've looked at in the slides earlier. Specifically around this age, they're going to be patients that have problems with pain crises. So this is a time that is potentially very, very significant for these patients. So what is extremely interesting is that there were multiple case studies and case series looking at a possible protective effect of fetal hemoglobin. And there was a seminal paper in 1994 looking at mortality in sickle cell disease. And what was found that was really fascinating was that there was a large volume of patients that were looked at, and those that had a naturally occurring increased percent of hemoglobin F, specifically above 8.6%, were noted to have an increased survival compared to those who had a number less than 8.6%. And you can see this rather dramatic Kaplan-Meier curve on the left, looking at how different those that had this threshold versus those that didn't, how well they did. So the conclusion from this data was that the persistence of hemoglobin F can alleviate symptoms in patients with sickle cell disease. So there is a unique subset of patients who naturally continue to express hemoglobin F into adulthood. And that you may find just incidentally in patients, or you may be looking at it with an electrophoresis when you're determining what patient's clinical status might be like. And that is called hereditary persistence of hemoglobin F. And these are patients that, again, had not only improved overall survival, but also did have a reduction or a minimization of potential symptoms. And you can see in the photo on the right-hand side, as the percent F started to increase, patients had less and less in terms of the types of complications that they had related to their disease. I did want to just comment that we talked very briefly in the beginning that hydroxyurea works by increasing hemoglobin F percentages. And that is the same idea behind what we're talking about with patients doing better with a higher hemoglobin F level. But you can see with this graph in that kind of 9 to 18% range is what you would see the hemoglobin F go up to in a patient with sickle cell disease who is being compliant with taking their daily hydroxyurea. So as we did case series, you could note that patients were having even less symptoms as that percent F started to go up even higher. Also, as an interesting insight, there were genetic studies that discovered that genomic variation leading to a decreased expression of BCL11A did increase hemoglobin F expression. So there seems to be, again, a very high correlation between hemoglobin F expression and a decreased symptoms in sickle cell, as well as then pairing that with this information that BCL11A represses hemoglobin F production. So therefore, decreasing the expression of BCL11A may increase the hemoglobin F production. And that is essentially the cornerstone for what we are using CRISPR-Cas9 for this disease, with that as the end goal. So as a very high level, CRISPR-Cas9 consists of Cas9 enzyme and a single guide RNA. And then, of course, that functions as a unit to edit DNA only at a targeted and precise location. And then during repair of the edited DNA, change in the target DNA sequence is introduced. And then that would inactivate or alter the gene that you are editing, and that would change, therefore, the function ultimately of the DNA. So there were multiple manufacturing processes done through these various companies in order to achieve high editing rates in the cells. And so that was something that is demonstrated on the right-hand side with just editing efficiency in normal human CD34 cells in vitro. And you see that the allelic editing is around 80% for these initial healthy subjects. So preclinical data regarding fetal hemoglobin as a percentage of total hemoglobin after editing and differentiation of erythroid cells. You can see the difference between the control and the edited cells on the left-hand side. Again, these are 10 healthy donors, and you can see with the editing of those cells, the percent fetal hemoglobin was up and up into the high 20s, low 30 ranges. Okay, so CRISPR-Cas9 mediated editing of BCL11A does increase the hemoglobin F levels. So you again are reducing the expression of BCL11A to shut off this switch. And that is then giving you an increase in production of hemoglobin F. And this product, known as CTX-001, or now commercially known as Casgevy, is produced using ex vivo editing of the reservoir enhancer region of BCL11A in CD34 positive hematopoietic stem cell precursors, and again reduces the erythroid specific expression of BCL11A. This is a graphic for what the gene editing approach looks like. The patient undergoes apheresis as an inpatient or outpatient, depending upon the situation, in a pheresis unit, and then cells are collected, sent for manufacturing, with the end goal, of course, of changing the BCL11A expression, leading to ideally an increase in hemoglobin F and a normal red cell as your end product. So I have been very involved with the pivotal phase 3 trials of exa-cel in multiple patients, and it's really been an honor of my career in order to be able to do so. And that's some of the data I want to just briefly share with you today. The idea is that you are going to collect these cells, you are going to edit them, and then you're going to return them to the patient through an IV infusion after they receive a conditioning regimen, single agent with the drug busulfan. And then you're going to infuse, after the myeloablation, you're going to infuse these manufactured cells, and then patients are going to be monitored closely while they're waiting for neutrophil and platelet engraftment. We have data on this slide for 44 participants. The age was 12 to 35 years. They did have to have genotype confirmation of their genetic diagnosis, and in order to enroll, they needed to have 2 or more severe VOCs in the prior 2 years prior to enrollment. And the primary efficacy endpoints were VOC-free for 12 or greater consecutive months, and secondary endpoints were those that were hospitalization-free for the 12-month period as well. This is a brief slide as to what their demographics look like. Pretty well distributed in terms of age and gender. But what I did want to comment on is the bottom 2 notes: historical VOC episodes per year. You see these patients are having about 4 severe VOCs annually, and they are having somewhere around 2 to 3 inpatient hospital admissions during this time as well. Patients did require an average of 2 mobilization cycles in order to successfully collect enough cells for the manufacturing process. And then you see the follow-up in terms of months that has been published in this seminal New England Journal paper in 2024. The data for both neutrophil and platelet engraftment are at the bottom of the slide: 27 days average for neutrophil engraftment and 35 days for platelet engraftment. And you can see here the really profound effect that this treatment had on these patients. So patients that met the primary endpoint of veno-occlusive disease-free for 12 or greater months was close to 100%. It was 96.7%. And the secondary endpoint for those that were free from hospital admissions were also very, very high. This is the waterfall plot to look at what each patient specifically looked like. And on the left-hand side is the pre-screening, pre-enrollment, what they historically had for their veno-occlusive crises. So each diamond there is representing a VOC event. And then you see, as we start to go into the right side, after they have been infused and over time, up to 48 months for the longest patient here, you can see that many of them had zero VOC events during this period of time, which is really, really, really quite significant. So 28 of 29 participants remained VOC through follow-up. One participant did have a VOC event that was concomitant with a parvovirus infection. So that was the only one that was noted. And since that infection has been treated and resolved, the patient has subsequently been VOC free. So you see there is just really, really, really dramatic improvement with how these patients have done after their infusions. This is longer follow-up going out into the 60-month time frame. It includes the data that we looked at earlier, just bringing data for a longer period of time. And you can continue to see that over time, these patients continue to do extremely well. And then pain events that did happen after infusion generally occurred in adult patients that had a history of chronic pain. One thing that is very important to note is that this treatment does not take away any prior damage that has been done because of the sickle cell disease, so it doesn't change any end organ damage, particularly if these patients have bone disease such as avascular necrosis. It's not going to take away chronic pain related to that. So those were thought to be many of the events that were the reported pain events when they were independently adjudicated. This is the hospital-free time. The secondary endpoint, you see every patient, 100% were hospital-free for the 12 months. And remember, we looked at the demographics. These were patients who were getting admitted 3 times annually. And then this is ongoing data to look at durable effect in avoiding the inpatient hospitalizations, and you see it's quite impressive as well. And this is the longer duration time period, just to give you a little bit of sense. Over time, patients continue to do extremely well. Okay, the other things that are very important is that there is an early and sustained increase in the total hemoglobin as well as the total hemoglobin percentage. So you see the black line at the top is patients' hemoglobin levels over time. Usually patients are having a hemoglobin probably mean more in the 7.5 to 8.5 range with their diagnosis of sickle cell. And you see over time, these numbers are dramatically improved into what is a normal range of around 12. And then you can see this sustained expression of hemoglobin F for these patients as well in the lower graph. And this is the mean percentage of fetal hemoglobin was around 37% at month 3, and over time did increase slightly to be a goal of over 40% during their long-term follow-up. Other important information is that there was pan-cellular distribution of fetal hemoglobin, so it was not in certain specific cells, it was pan-distributed. So we start to see this in at least 93% of red cells expressing fetal hemoglobin from month 6 onward. And then also durability for exocell gene editing over time, looking at durability in both bone marrow CD34 cells as well as blood nucleated cells over time. And you can see that is maintained as well. We talked in the beginning about what these patients start to have as not only their clinical symptoms, but what their laboratory work looks like. And we mentioned that markers of ongoing hemolysis include an elevated LDH, a decrease in haptoglobin, also bilirubins and reticulocyte counts are trended and well reported and well described. The graph you see on the right is looking at LDH, which is a marker of cell turnover, and you see that those numbers have come down quite a bit from where they're kind of 2 times upper limit of normal to kind of normal maintained over this 24-month post-infusion time period. Also important to note is that we do patient-reported outcomes, and across all of the instruments that were used, across all domains that were evaluated, physical, emotions, social, emotional, social, etc., patients all described substantial and clinically meaningful benefit. This is an overview of adverse events and severe adverse events related to this patient journey and patient process. We can talk in more details about this, but the most common adverse events are on the right-hand side, the majority of which are related to the myeloablative conditioning with the busulfan conditioning, and not thought to be specifically related to the gene-edited cell infusion. So in conclusion, these patients achieved VOC-free and no inpatient hospitalizations for VOCs for what we followed now for 46 months. 96.7% achieved a 12 or greater consecutive months without having a veno-occlusive pain crises, and 100% achieved a 12 or greater consecutive months free from inpatient hospitalizations. These patients had rapid, robust, and durable increases in total hemoglobin to normal or near normal levels, as well as a pancellular distribution, an increase of hemoglobin F well over 20%. As mentioned also, we have demonstrated durable editing of hematopoietic stem cells and shown a clinically meaningful improvement in hemolytic markers as well as quality of life assessments. And the safety profile is consistent with what we generally would talk to patients about in the transplant community related to myeloablative busulfan conditioning and autologous stem cell transplant. There were no malignancies and no serious adverse events specifically related to exa-cel. So I think just high level advantages, of course, bringing this back to what are our current treatment options. We talked a lot about in the beginning about the ability to do transplant for these patients. Clearly, an advantage with gene editing is that you don't need to find a donor. Patients are able to donate the cells to themselves. There's no risk of acute or chronic graft versus host disease, and patients recover much quicker because they are getting an auto. They're getting their own stem cells back than if they were having an unrelated or related stem cell source where patients would need to use immunosuppression for a long period of time. Of course, we continue to follow long-term what this data looks like. We don't yet have data for what this process would look like in patients who have had strokes. That's the next wave of clinical trials that will be coming. One of the exclusion criteria initially for these initial trials was to exclude those who did have an overt stroke previously. So hopefully that will be in the new generation of data to come. So I think that was it. I know I had a lot, but I wanted to just end with maybe this slide, which I think is quite profound. You see, this is an actual patient that was on the trial. This is the patient's blood smear pre-infusion. So just what their baseline lab peripheral blood smear looks like, and you can see all of these sickled cells in the sample. And when we have months later looked at their peripheral blood sample again, they have no evidence of sickled cells on their smear. So quite profound, and I think a really nice way to end this talk with seeing how in real life we're seeing these changes. It's quite fascinating. This was another patient who had similar, and you can again see how amazing this blood smear looks. And this was our very first patient. Not only was it our first patient at Sarah Cannon in Nashville, but she also was the first patient in the world to be treated. And I really encourage you to go online and read about her story. Victoria is a very, very amazing woman to have taken this on as the first person in the world to undergo the treatment. She's the one with the longest follow-up that you see in all of our data. And I would just really encourage you to hear about her story. That's her with her children in the bottom right. So it really has revolutionized her life quite a bit. And there are many patients now who have been sharing their story in the media. So I would encourage you to go and learn more about them as well. Thank you.
Thanks a lot, Dr. Dunn. This is really exciting. We got lots of good questions waiting for you.
Okay.
So some are just basically curious about sickle cell disease. For example, why do you think the prevalence of the disease is more in certain ethnic groups than the others?
Oh, great question. So one thing that is very, very interesting about sickle cell disease is that there is thought to be evolutionary advantage for patients that have sickle cell disease for exposure to malaria. So we think that it has evolved the way that we looked at in the prevalence data in certain populations, because those are also populations that have an increased exposure to malarial diseases. So we think evolutionarily, that is how and why this has persisted in the general population.
That's fascinating.
Mhm.
So a lot of questions are about the relationship between hemoglobin A and F. How are they related? How are they switching from one to the other? Can you comment on that?
I'm not sure specifically what the question is about, but I think in general, I think as we looked at in some of those slides, the natural evolution is, again, the switch from F to A is going back to, again, the need for oxygen exchange changes dramatically when you're born and you take that first breath with your own lungs. The F is designed to have a very high oxygen affinity in utero so that it can extract oxygen from the placenta, because of course the blood has already gone through the mother's system, so she's already extracted the oxygen that she needs, and the F is designed in order to extract even more oxygen after, again, having already been through her circulation. So not sure if I'm answering the specific question that somebody had, but that's what we're taking advantage of with this process.
Then their question is, if you just increase the hemoglobin F, is it still necessary you have to decrease or inhibit hemoglobin A to get the treatment effects that you're targeting?
No, I don't think so. I think what is happening is that by switching off the BCL11A, you're essentially reverting to what you are doing in utero. And so I think because of the mechanism of action and what we're turning off, that is leading to more production of F. Remember, for people that have sickle cell disease, instead of A, they are having S as their main source of hemoglobin. So they're having more S that's in the 90+% range, and they're not necessarily making any A. So you're switching basically the S, the sickle, to F fetal in these patients.
There are more questions also about the study, the clinical study. So is there an age upper limit for participants who are benefited from this treatment?
Yes, the trials that we just looked at is for those that were 35 years as a maximum age. So that was trial. There are new trials going on, as we mentioned, looking at new subsets of patients, including different hemoglobinopathies, looking at different comorbidities, also looking at different ages. But one thing that is important to note is that this is now an FDA-approved product and is an approved commercial product. So I'm emphasizing that because that potentially can change the ages that we use this product for in patients because it is commercially available. So the trials were looking at the younger patients. And the reason for that, of course, was we looked in the beginning that the mortality for these patients is quite high with the average age of being 48 years. So as patients obviously get older, they have more and more end organ damage. And the idea with designing the trial with these ages was to have the healthier adults, so the younger ones that didn't have comorbidities that would affect the ability to receive myeloablative conditioning for transplant.
Yeah, I think this is a follow-up question. I think you already touched upon a little bit. Is what's the ideal participant you think would most benefit from this treatment? I think what you're saying is younger, has less comorbidities, seems to be better target for this treatment.
I think it's very important to note that, again, this treatment does not reverse damage that has already happened. It only helps future. So I think as an example, if you have a vascular necrosis or you now have chronic pain because of some of your comorbidities, it will not reverse those things. Patients may still need to go on to have a joint replacement, for example. They may need treatment for the things that have happened. So bringing this to a younger age group would definitely be ideal. It still should, I think, be explored in patients, in any patients, because again, if they're having a lot of complications, it still may potentially be of help. Of course, there's a long process to make sure that it's safe to proceed, but I think the younger the better before you're having a lot of end organ damage would be advantageous. And we are going to start to look at doing this in younger and younger persons as well, including children.
I think given the time, let's move on to the general question about gene editing. So I think the main theme are two. One is, can you comment on the potential, of target effects of gene editing?
Yes. To date, I mean, this is something that is being followed long-term in clinical trials, including there are certain time points where people are having bone marrow biopsies performed as part of a trial to evaluate for off-targeted editing. There has been nothing identified to date. Of course, the data will continue to be followed long-term. But I'm very optimistic that the fact that this is such a precise gene editing technique and perhaps not a different way to introduce the changes, that this will be something that will have very limited, hopefully no off-target editing.
Great. I share your optimism. Last is, I think the elephant in the room is those gene editings are just so expensive. They're all in the $1 million range. So do you think the insurance are covering for it, or, how can they be more, accessible for patients?
Yes, and that's something that we're starting to get a lot more knowledge about, given, again, the fact that it is now available commercially, and it has been something that has, challenged the insurance companies in order to determine how that this will be reimbursed. Of course, if you take over long term, the lifespan of a patient, you look at all of these hospital admissions and possible, again, organ damage, pain, etc. Those costs probably over lifetime are more significant than what this would be. But because it is a new way to approach the disease and a very large price tag up front, it is something that is being worked out, I think it's fair to say, as we go. So I think right now, it's important to consider this as an option, to at least be knowledgeable about it. and then to work with a center that has familiarity with this and can work with insurance companies to get this approved. So I have been involved in many cases so far where we have submitted to insurance and it seems to be going smoothly. But again, it's just starting on the uptick, so I think time will certainly tell.
So I think a last question is more speculative. So this is a success story in sickle cell disease. Um, so what do you think would be the next disease that would have benefited from this breakthrough technology?
Oh, well, I think I don't know specifically about the next disease. I think for me, because this is as a hematologist, oncologist, and transplant physician, I think the next wave for me is looking at some of these challenging subsets of patients that have specifically, as we talked about with stroke, um, seeing how those patients would do. I think there's many, many, many investigations into other disease processes, including neurodegenerative diseases. I think there's been many publications about use in various ophthalmologic eye conditions. So I think, it's not infrequent to look at the table of contents for New England Journal of Medicine and see a new disease that this is being looked at. So I think it's opening up an incredible new world for how we're going to start to approach medicine and diseases.
So I think with that, I wanted to ask, any final thoughts you wanted to share with the audience?
Well, I think my thoughts on coming from my own perspective, and that being a clinician on the ground meeting these patients. And I think what I talk about all the time that's most important is that people and patients and families become knowledgeable about some of these very exciting new treatment options. It may not be the right thing for you, but it may also be the right thing for you. So I think without knowing that this exists and without exploring it as an option, you will never know. So I think as a provider, it's my responsibility to make sure I educate people about all of the different options and make sure that we work together to figure out the right thing for the individual patient. But you cannot make an educated decision without knowing that this exists and that this is a possibility. So I do encourage, I think one of the reasons why I love doing very broad talks like this is to get the information out there. So if you know of anybody who has sickle cell and is struggling, I would encourage you to pass along this information so that they can bring it to their providers and learn more. Knowledge, of course, is power.
Thank you very much. This is really inspiring. As a neuroscientist for 2 decades, I mean, when I started my career, I worked on Huntington's disease, a single cell mutation. We're not there yet, but I think, one day if we can treat that with gene editing,
Absolutely.
that would be
Absolutely. Absolutely.
exciting.
Well, just the last little bit. If you enjoyed today's event, there's next year coming up. And some of these will be great collaborations with ACS. And in time for Halloween, we'll be talking about the undead. That one's going to be particularly fascinating. Are we dead yet? And then we'll be doing a program for World AIDS Day. We'll be looking at geothermal technologies and nuclear technologies in January. And in April, we'll be talking about going back to the past, looking at ways from the past that we can clean the environment today. Finally, all of these great free programs are kindly supported by our generous donors. And if you'd like to join the group and receive our print edition of Distillations each June, it's easy to do by giving online.
Thank you for watching this presentation. ACS Webinars is provided as a service by the American Chemical Society as your professional source for live weekly discussions and presentations that connect you with subject matter experts and global thought leaders concerning today's relevant professional issues in the chemical sciences, management, and business.